Welcome to everyone. We're so glad you're here today. My name is Dora Barilla. I'm with HC2 Strategies, and we have a wonderful agenda for you guys today. If you want to put your name and in the chat, we'd love to see who's with us, but we want to welcome you all. We want to remind you just to keep yourself on mute and put your name and organization in the chat so we just know who's here. Again, this is Privacy Compliance Explained for community-based organizations, and we're really thrilled to have you. We're going to give it about another minute or so before we get started. So we encourage you to get a virtual chair and get comfortable, and we'll get started in about a minute, and we'll just acknowledge everyone that's joining through the chat. So welcome, Lori. We're so glad that you're here. For those of you that are just coming in, we're just getting started here. If you want to put your name and organization in the chat, that would be wonderful, so we know who's on the call. All right. Welcome, Danielle. Rachel, it's great to have you. All right. Well, it looks like we're just about straight up at 2 o'clock. And so we've got a very full agenda. So I'm going to go ahead and get started. But again, my name is Dora Barilla, and I'm with HC2 Strategies. And we're really thrilled to have you here today for our webinar. Or we want to encourage you all to put yourself on mute, but put your name and organization in the chat. And we really hope that you enjoy the time together. The overview of what we're going to be talking about today is privacy explained for community-based organizations, really navigating HIPAA, privacy laws, and technology for care coordination. So often, as California it continues to integrate community-based organizations into the healthcare delivery system, it's so important that community-based organizations have the ability to share data with their healthcare partners. And today we hope to demystify federal and state privacy laws as really break down, as well as a breakdown on how technology can support compliance, to ease concerns, and really to support that data exchange efforts with community-based organizations. So we will really be focusing in on how you can better do your job by sharing data and ensuring that relevant privacy laws that regulate how CBOs can receive and disclose information, really understand the technology and how you can support compliance, as well as identify solutions to support data sharing efforts with community-based organizations. So we all know we're in a new era of data sharing, and we're really blessed to have a speaker panel that is as experienced as the one that we have today. So I'm going to do a brief overview, and I'm going to turn it over to our experts. So first we'll be started by Lauren Harden from HC2 Strategies. Lauren is the Chief Integration Officer, and Lauren is a nationally recognized leader, very highly skilled at partnering with communities, health systems, and payers to co-design models and intervention for complex populations. Lauren has been a senior advisor for the inaugural team that developed the Camden Coalition's National Center for Complex Health and Social Needs. Lauren has really been an entrepreneur and a leader. She was recently appointed as the first nurse representative and co-chair of the U.S. Government Accountability's Office Physician-Focused Payment Model Technical Advisory Committee, or as we call it, PTAC. So we're really fortunate to have Lauren as our first speaker from HC2 Strategies. And then we have Andrea Frey, who is Senior Counsel with Hooper, Lundy, and Bookman, one of the participants in the webinar today. And Andrea really specializes in digital health, data privacy, and security issues, and regularly counsels hospitals, health systems, and medical groups and digital health providers in navigating the complex web of federal and state health privacy laws that govern confidentiality and exchange of health information. These include the federal laws like HIPAA, the information blocking rules and substance use disorder privacy regulations, as well as state laws like California's Confidentiality of Medical Information Act. Andrea, frequently works with clients on implementing measures to safeguard their data and offers tools to leverage data in a compliant manner, such as through data use agreements and data licenses. And then our third speaker is one of our other sponsors. John Weir is a managing director from Blue Path Health. And John is a managing director with Blue Path, where he leads a variety of technology and process improvement initiatives. With over 25 years of experience in healthcare IT and passion to improve healthcare data use to reduce cost and improve decision-making across the healthcare system, John has worked with provider networks, payers, and technology vendors to optimize access to actionable information and improve the quality of care. Needless to say, John's work has really been focused on safety net providers, community-based organizations, to really incorporate solutions that support care coordination and data sharing under both whole person care and now CalAIM. You couldn't be in better hands today with Lauren, Andrea, and John. And so I will turn it over to Lauren to get our day started. Thank you, Lauren. Oh, I'm sorry. Lauren, you can go through a few of the housekeeping.
Great. So you have the ability to mute and unmute, but we'd like to hold questions until at the end of the presentation. We know there's great information you're gonna want to hear. And this event is being recorded and the slides will be distributed. I know how many people want to learn about this, and I know you'll be passing this on. And if you have any unanswered questions at the end of this session, we do have 2 office hours later this month where you can join for even deeper discussion, and there are many resources included at the end of the slides. So let's jump in. I am really excited to be part of this session. We're going to be covering data sharing and care collaboration, privacy law considerations, technical considerations, and then case discussion and Q&A. So for my section, I'm just thrilled that we're having this session. I've been caring directly for complex populations for many years. I originally led a complex care center serving all of the populations covered in CalAIM. And I learned very quickly that the way I was going to help people the most and actually change the system of care was by collaborating across sectors. But of course, right away, I ran into people's fears and misconceptions about HIPAA. Could we or could we not collaborate, and what were the structures? So I'm really excited to dive in with these experts today. So with CalAIM, we have this wonderful opportunity to really integrate across sectors, understand our most vulnerable neighbors, really build integrated systems to meet their needs, collaborate to develop solutions, and create shared plans of care. As part of that, we have new partners. So on the next slide, you'll see a representation of how different sectors are really starting to come together. I'm very excited to see this because our partners across systems, if we come together in a shared response, we're going to be able to improve people's lives so much more, as well as build a stronger system of response for our community. So housing supports, healthcare systems, child welfare, behavioral health, treatment facilities, emergency transport, justice involved, schools, even faith communities are involved in delivery under CalAIM. So it's a real opportunity for us to really understand how do we come together. On the next slide, you'll see a definition from New York State. So case conferencing is a practice that's really focused on bringing people together across sectors. Typically, it's interdisciplinary, includes at least one or more external providers. And the intent of that is to develop a whole person shared plan of care and really collaborate to meet complex needs. You may think this is only coming up in California, but I have had the privilege of doing this directly myself and then working with communities all over the country who are exploring this practice. And what's happening in value-based care across the country is case conferencing is being built in as a core strategy to really improve outcomes. I've had the privilege of working with 3 different communities. I'll briefly tell you their story. And linked in the slides, it goes directly to an article where you can learn more. So I worked with Memphis, Tennessee, with Regional One Health, and they were designing a model for uninsured populations. So in that model, we learned very quickly. So Tennessee did not expand Medicaid. So 30% of their population had no insurance. Imagine how complex their health and social needs were. So collaborating across sectors was critical for stabilization and to really build an improved response system. And this article explains it more. Case conferencing was key in that. Right here in California, Lake County, California, way before CalAIM started, built Project Restoration, a coordinated approach that included cross-sector partners, behavioral health, hospitals, the fire department, the mayor, 911, emergency response services, really collaborating together to help their most vulnerable neighbors and work on process improvements. This peer-reviewed article shows their outcomes that include case conferencing. And then finally, in St. Louis, a whole citywide approach. So the Behavioral Health Network of St. Louis is a really exciting integrator organization. And we built together a collaborative approach of all the hospitals, the homeless response system, and community-based organizations coming together to do cross-sector case conferencing across the city. So diving into some of those populations that many of you may have heard, oh, no, we can't talk about behavioral health, or we can't talk about substance use disorder. So this article shows their outcomes, and you'll hear more about how can we build connection, respecting privacy laws, but really meeting the needs of clients. So 3 common California scenarios coming up where you may want to be collaborating and really understanding the needs of the population. One kind of case conferencing might be an enhanced care management or community supports provider wanting to pull together different agencies involved with one person into a one-time case conference. So you want to come together, develop a shared plan of care, help each other meet the diverse needs, whether it's food security, transportation, health, or behavioral health needs. So that's one kind of scenario. Another scenario might be a community-wide case conferencing table where all the enhanced care managers and community supports providers come together and talk about their most complex community members that they're trying to serve and collaborate to meet their needs. So it's a broader table and it's focused on a population versus just one individual. And then a third scenario I'm seeing come up with CalAIM is people really wanting individuals in their community to get access to services. So they're looking at, for example, from the homeless management information system, putting out a client list of who might qualify for CalAIM and then comparing that list with another agency to try to get services, get referrals, get integration. So I'm sure you'll think of more, but these were a couple of scenarios that we might see case conferencing and privacy and data sharing show up in California. And I'm really excited to turn this over to Andrea, who's going to take you through the legal aspects of this component.
Yeah, thanks so much, Lauren, and thank you to Dora for the introduction. I'm really happy to be here today, certainly as part of my practice since the implementation of CalAIM has been to advise CBOs on the applicability of HIPAA and other various privacy laws. So, I think this will be, my intention with these next couple of slides and my portion of the presentation is to kind of walk through some of the questions that we, frequently get from these kind of organizations and analyzing, what exactly is HIPAA? Does it apply to me? And how so? And what are the obligations if it does? So to kind of kick things off, I wanted to start with, what is HIPAA? To set the ground here for everyone on the call. As a reminder, the HIPAA stands for Health Insurance Portability and Accountability Act of 1996. It includes implementing regulations under the privacy, security, and breach notification rules that really are focused on kind of protecting the privacy and security of protected health information and giving patients rights with regard to their health information. So for this portion, my portion of the presentation, I'm really going to be focusing kind of as a general matter on the considerations under the privacy rule when it comes to the use and sharing of protected health information. But first, I think it makes sense to start with kind of a quick primer on who applied or who is subject to HIPAA. And so as an initial matter, HIPAA establishes standards to safeguard PHI that's held by certain regulated entities, including covered entities and their business associates. So by law, covered entities include the types of entities that are listed on this slide, such as health plans like HMOs, company health plans, government health plans, and the like, healthcare clearinghouses, which are generally kind of entities that process non-standard health information from one entity to another. And then finally, and kind of most relevant to today's presentation, the last bucket, covered entities includes healthcare providers that conduct certain healthcare transactions electronically. So let's dig into these definitions a bit more in the context of healthcare providers. So, reviewing some of the established definitions in our HIPAA regarding the classification as entities as covered entities. Again, a covered entity, for our purposes, we're focusing today on the inclusion of healthcare providers who transmit any health information in electronic form in connection with a covered transaction. And so a healthcare provider basically includes any person or organization that furnishes, bills, or is paid for healthcare in the normal course of business. And then broadly speaking, healthcare under HIPAA is defined as sort of any services or supplies that are provided that relate to the individual's health, including, for example, preventive, therapeutic, rehabilitative, maintenance, or palliative care, as well as kind of any function or service that kind of affects the structure or function of the individual body. And so, I just want to kind of flag here, this definition, of healthcare is so broad to include kind of any services that are related to the health of an individual, that, certainly this could encompass the services your organization may be providing under CalAIM. And we'll get into this in a bit more, but, to the extent you're contracted with a health plan, for example, to provide case coordination or care management or care coordination services directly to patients, and you're transmitting protected health information back to the plan, in an electronic form, then you may well qualify as a covered entity. And then finally, just to kind of, briefly end here with the definition of transactions. So as used to kind of, in the definition of covered entity, transaction includes kind of specific instances in which there's an electronic exchange of healthcare data. And these include probably the most common types of covered transactions under HIPAA, include where a covered entity is electronically submitting claims to insurance companies for payment and reimbursement purposes. So oftentimes, there is some confusion as to who HIPAA applies to in the context of, say, you're a cash pay organization and you're not actually submitting claims to a health plan. Oftentimes that's where most kind of healthcare providers fall into, HIPAA, if they're providing services and electronically billing for them. That's probably, like I said, the most common healthcare transaction. So, something to consider here too, if you are participating in CalAIM and contracted with a health plan and submitting those claims electronically. So, I also just mentioned that HIPAA applies to entities that qualify as business associates. So kind of just a bit of legal nuance here. Technically, the privacy rule itself only applies to covered entities. However, the privacy rule does recognize that there are going to be instances in which healthcare providers have to rely on vendors, contractors, and the like to carry out kind of their healthcare activities and related operations. And so under the privacy rule, then covered entities are allowed to disclose protected health information to another entity in its function or role as a business associate to the covered entity. But the PHI can only be shared with that business associate to the extent it's providing certain covered services and functions on behalf of the covered entity. The business associate itself cannot receive PHI from a covered entity for its own purposes, with the exception, for example, of if it's required to share the information by law, or if it's for general management and administration purposes, which the agency that oversees HIPAA defines very narrowly. So, at the end of the day, sharing of protected health information, though, between one healthcare provider and another healthcare provider that's for treatment purposes, that does not give rise to a business associate relationship, since the covered entity is using the PHI, or excuse me, since the receiving entity is using the PHI from the disclosing entity for its own purposes to provide treatment to the individual patient. And so, in speaking with Lauren kind of in the lead up to this presentation, I understand, there are many instances in which organizations believe a business associate agreement may be necessary, for example, when it's not actually the case because there isn't this kind of underlying business associate relationship at issue. And so, I kind of jumped ahead there, but I should also note too that if there is a business associate relationship, a business associate agreement is required, and that's basically this contractual obligation that sets out satisfactory assurances by the business associate that it's only going to be using the protected health information for certain purposes for which it was engaged by the covered entity, the kind of obligations to comply with the privacy rule, and for example, that it will return and destroy any protected health information at the conclusion of the relationship. So breaking down kind of a bit more into what a business associate is, the regulations define a business associate as a business that creates, receives, maintains, or transmits PHI on behalf of a covered entity to carry out specific services, healthcare activities, or functions on the covered entity's behalf. And so kind of most commonly we think of, for example, like claims processing, administration, data analysis, utilization review, those kind of services in which a covered entity specifically contracts with an organization to provide these services that ultimately facilitate the covered entity's provision of healthcare and healthcare operations. Again, the business associate does not include receiving entities for treatment purposes. I just want to note here too, in kind of analyzing the applicability of HIPAA as either a covered entity or as a business associate, when it comes to data rights, organizations will generally be better served by acting as a covered entity because that means it will generally own all of the encounter data that's generated from providing the services. Whereas if you are a business associate and you enter into a business associate agreement, that really limits your ability to use and disclose protected health information because you have to do it within the confines of the business associate agreement. And, which means you are doing it for the limited purpose of providing services to the covered entity. And then at the conclusion of the relationship, as I noted on the last slide, you generally have to return or destroy PHI when the relationship is over. So just something to keep in mind there. Okay, so breaking this down a bit more, I pulled these graphics from a handy dandy tool that CMS has on its website called Covered Entity Decision Tool. So just, basically the main questions to ask yourself in terms of whether or not you're a covered entity include, first, are you furnishing, providing, billing, or receiving payment for healthcare services in the normal course of business? And are you transmitting kind of any covered transactions electronically? And so again, the most common being submitting claims for, reimbursement purposes to health plans electronically. And, ultimately, if the answer is yes to both, you're most likely going to be a covered entity. So, kind of getting back to what we've been talking about all along, CalAIM mandates that managed care plans offer enhanced care management, which includes intensive care coordination, of health and health-related services by CBOs, as well as community support services. And so ultimately, if you are a CalAIM, ECM, or CS provider, contracted with a health plan and submitting claims electronically to that health plan when you provide those services to individuals, you may very well be a covered entity under HIPAA and subject to obligations under both the privacy rule and, as John will talk about a little bit, the security rule as well. So, if, turning back to the questions on the other slide, you responded no to either of them, then the kind of question comes up is, are there instances in which you may qualify as a business associate to a covered entity? And ultimately, the questions to kind of ask yourself are you providing services to or on behalf of a covered entity, like a healthcare provider or a health plan, to support the covered entity's payment or healthcare relations or healthcare operations? And if so, are you going to have access to protected health information from the covered entity specifically so that you can perform, that function or activity on behalf of the covered entity? If neither, if you are receiving protected health information from the covered entity or from an entity that qualifies as a covered entity under HIPAA, if the purposes in which you're receiving that is in order to provide services directly to an individual and not on behalf of the covered entity itself, and not to perform any sort of covered function on behalf of the entity, then most likely you are not a business associate, meaning there's no need for a business associate agreement. There are, however, nuances here about how and whether or not covered entities can share PHI in those circumstances, which we will get into. So kind of doing another quick primer here too on the privacy rule. So, under HIPAA, the privacy rule really is intended to kind of protect patients' protected health information that's held or transmitted in any form, by a covered entity or a business associate. And really focuses on governing kind of the permitted, required, and prohibited uses and disclosures of protected health information, while also providing patients with certain rights, for example, to access their protected health information, to amend it, and the like. And so just a couple quick notes here, at its core, fundamentally, the permitted uses and disclosures, to the extent there is not an authorization that's signed by the individual patient or the patient's representative, HIPAA allows covered entities and their business associates to use or disclose PHI, for example, with regard to treatment, payment, and healthcare operations purposes, disclosures directly to the patient or the representative, disclosures that are explicitly required by law. So say, for example, in the instance of reporting suspected or actual child abuse, or, some other kind of public health communicable disease reporting requirements and the like. And then finally, another permitted example is disclosures that are required pursuant to a court order or a validly served subpoena. And then, as I noted, the privacy rule also really intends to kind of give patients certain rights with regard to their protected health information. And so if you are a covered entity subject to the privacy rule, one of the obligations, for example, is to include a notice of privacy practices. And I'm sure, as patients, we actually have to acknowledge it every time we're receiving services from a healthcare provider. So I'm sure you've seen it. Usually it's also posted on the healthcare provider's website. So that's, for example, one obligation of the privacy rule. Another is the requirement to adopt privacy policies and procedures and to train members of your workforce on them, as well as to assign, an individual within your organization and the role as a privacy officer to make sure, for example, that you're adopting and kind of following the privacy procedures internally as well. So, getting more into kind of the basics here around sharing of healthcare information, as I've noted, for treatment purposes, the privacy rule does specifically allow for covered entities to share protected health information, even without assigned consent from the patient, for purposes of treatment of the individual patient. Payment as well. I should note healthcare operations. There are also permitted disclosures that may be made for healthcare operations between covered entities, but HIPAA does limit these only to instances in which both covered entities have a mutual relationship with the patient. And it only is limited to, for example, peer review, quality assessment, and other kind of purposes. So just keep that in mind. But I think for kind of our takeaway here, I just want to focus on the treatment, the ability to disclose and use PHI for treatment, which HIPAA really sort of broadly defines as kind of the provision, coordination, or management of healthcare and related services by healthcare providers, including the coordination and management of a healthcare by a healthcare provider with a third party, as well as kind of consultation between healthcare providers relating to a patient, or the referral of a patient from one healthcare provider to another. And so, again, HIPAA explicitly allows for the exchange of PHI for treatment purposes, and the instances in which you'd be sharing for treatment would not require a business associate agreement between the two covered entities because there's no business associate relationship at issue there. So what about instances in which covered entities are sharing protected health information, again, for treatment purposes, as we just defined it, but to a non-covered entity? And so there's an FAQ that actually OCR, Office for Civil Rights, which is the agency that oversees and enforces HIPAA, has posted on its website. And in this particular guidance kind of provides the following example of whether the privacy rule permits covered healthcare providers to disclose PHI to public or private sector entities that provide health-related, social, and community-based services as part of the disclosing providers' treatment services, but that aren't themselves considered a healthcare provider. And in response, the guidance kind of explains the circumstances in which the privacy rule does actually permit a healthcare provider to disclose PHI to a third party, even though that third party is not considered a healthcare provider as a covered entity under HIPAA, provided that the purpose of the disclosure is really part of the broader health treatment plan of the individual, or in connection with coordinating, the care that's being provided to that individual. The guidance does note, though, that the disclosure remains subject to what's called the minimum necessary standard under HIPAA. And so essentially what that means is the covered entity is obligated to only share the minimum amount of protected health information that's necessary to fulfill the purpose for which it's being served. So it may be the case that the covered entity in its reasonable discretion decides we're only sharing XYZ patient identifiers and health information because that's what complies with the minimum necessary standard, to the extent it is sharing PHI with a non-covered entity. I should note too, just before we move on, that HIPAA doesn't provide a definition for either care coordination or case management, but there has been commentary that Health and Human Services has released, in which it's kind of explained that the terms generally refer broadly to a set of activities aimed at promoting cooperation, among various kind of members of an individual's healthcare delivery team, and they specifically reference CBOs in that guidance. So, again, if you are an organization and potentially receiving protected health information from a covered entity, this guidance specifically speaks to instances in which you may receive protected health information. I should also note too that, in the alternative to having information shared pursuant to, treatment purposes, a covered entity can also, say, hey, we have this authorization from a patient, and obviously HIPAA permits the disclosure of PHI to the extent, the individual has signed a release of their information. So, for example, the authorization signed by the patient could say that the PHI will be disclosed to my social service providers, for purposes of housing, public benefits, counseling, et cetera. And in those instances, you wouldn't need to, you wouldn't be subject to the minimum necessary standard for the disclosure. It would just be subject to kind of the scope of the release that's authorized by the individual who signed the authorization form. Okay, so quick takeaways, under the HIPAA privacy rule for community-based organizations. Again, if your organization is a CalAIM ECM or CS provider who's contracted with a health plan and electronically submitting claims for payment to those plans, you may qualify as a covered entity under HIPAA, and therefore, kind of have the obligations under the privacy rule and security rule that flow through to your organization. You may also qualify as a business associate, but only in the event that you're performing covered functions on a covered entity's behalf. And as a reminder, in those instances, you would need a business associate agreement. If you're receiving, I should note, if you're receiving PHI to perform those functions on behalf of a covered entity. I kind of jumped the gun on this, but if you are a covered entity, your organization has to comply with the HIPAA privacy rule with respect to uses and disclosures of PHI. But again, under the broad treatment exception, you as an organization may share PHI for purposes of treating the individual with other covered entities and other healthcare providers. If you're a non-covered entity, you may still be able to receive protected health information from hospitals, pharmacies, and other covered entities for treatment purposes of the individual, but again, subject to the minimum necessary standard unless the patient has signed an authorization. Finally, and kind of leading directly into the next slide, there may be other health privacy laws beyond HIPAA that kind of implicate your ability, or rather the disclosing entity's ability, to share health information as well. So just kind of a quick reminder running through these, at the state law and at the federal law, there may be regulations imposing kind of confidentiality obligations with regard to information. For example, in the housing and WIC context, both the state and HUD and USDA do provide certain requirements around data privacy obligations with regard to that information. And then psychotherapy notes, HIPAA generally applies to any protected health information. It doesn't kind of break out or treat any health information differently, with the exception of psychotherapy notes. Notes that are recorded by a mental health professional, they're kind of basically notes that the health professional takes for their own purposes and not for purposes of treating the patient, and therefore they shouldn't be included in the patient's medical record. Those have more stringent requirements under HIPAA. And then at the federal level, we also have heightened confidentiality obligations for substance use disorder records. And so these really, I would say, are even more stringent requirements than under HIPAA. And so Part 2 programs, and these are basically any substance use disorder treatment referral programs that participate, in federal and receive federal funds and hold themselves out as providing SUD services, they're prohibited from disclosing any information that would identify a person as having a substance use disorder, unless, basically very limited, the patient provides written consent, there's a valid court order that's been issued, or the disclosure is for a medical emergency, audit, or evaluation, or research purposes. And then here in California, we also have a number of kind of various health privacy laws that could come into play as well. So for example, the California Confidentiality of Medical Information Act, which is very much kind of the analog to HIPAA in the state, but does provide certain heightened restrictions when it comes to outpatient behavioral health records. Then we also have the Lanterman-Petrus-Short Act, which protects certain mental health records created and maintained by usually county-funded facilities with regard to mental health services. And a little more strict in terms of abilities to use and disclose information that's subject to LPS than HIPAA is. And then there are other various privacy laws that kind of the state has. For example, I believe it's Health and Safety Code 11845.5, which is basically the state's analog to 42 CFR Part 2, protecting substance use disorder treatment records from DHCS, SUD facilities, and the like. There are, certain protections as well for HIV/AIDS test results. So, just kind of keep in mind, to the extent you are disclosing this information or you're receiving this information, that there may be kind of heightened laws at issue. With the caveat that AB 133, which gave rise to CalAIM and kind of recognizing the importance of information for the successful kind of implementation of CalAIM, did kind of create this new provision under Welfare and Institutions Code to promote kind of the freedom of data exchange and the ability to, really ensure effective care coordination by allowing data exchange, even in cases where state privacy laws may prohibit the disclosure without a consent form that's signed by the patient. And so what this means is kind of those laws that I just talked about that fall within the bucket of California privacy laws. This specific section in Welfare and Institutions Code says that, as long as the information is shared for the specific purpose of providing services or coordinating care for, CalAIM members, or receiving reimbursement for such services, or improving the quality of care delivered to members, in those instances, again, provided that you're still complying with federal law components like HIPAA and Part 2 to the extent applicable, in those instances, the sharing of information is permissible regardless of any prohibition under state privacy laws. And then just kind of wrapping up my portion too, in addition to modifying the Welfare and Institutions Code, I just want to talk briefly about how AB 133 also directed the state to develop kind of this first ever statewide data exchange framework, which includes kind of at its core components, a required statewide data sharing agreement, and a common set of policies and procedures that are focused on kind of connecting and expanding the secure exchange of health and social services information. And so the DSA, or the data sharing agreement, that really is kind of a signed agreement, a shared commitment among mandated and voluntary signatories to the DXF. For mandated participants, this includes hospitals, physician organizations, medical groups, health plans, skilled nursing facilities, clinical labs, and the like. But then it are also this bucket of voluntary signatories, including social services organizations, government agencies, and the like, to securely and appropriately share information. Ultimately, the goal is really to ensure that all health and social services providers have quick and easy information needed to safely and effectively treat California patients. And so, very much participation is voluntary, but very much encouraged for social services organizations. So to the extent you're interested in participating, I'd encourage you to check out all the resources that CDII, or Center for Data Insights and Innovation, has put on its website, and review the data sharing agreement, for example, as well as the P&Ps, or policies and procedures, because these really provide more of the detailed guidance in a number of areas. And so, review these to make sure, for example, if you decide to participate, that you can actually comply with all of the provisions. And so just wrapping up here, one of these policies and procedures that CDII has released and is relevant to today's discussion with regard to privacy standards is the appropriately named Privacy Standards and Security Safeguards Policy and Procedure. And so this really spells out the requirements for participating entities that are considered CEs, or covered entities, and business associates under HIPAA, essentially requiring that they comply with the HIPAA privacy and security rules when it comes to sharing and use of health and social services information. And then also for non-covered entities that are participating in the data exchange framework, going through essentially that you'd need to comply with both the HIPAA privacy rule regarding permitted uses and disclosures, including the minimum necessary standard, as well as certain provisions of the HIPAA security rule with regard to implementing appropriate safeguards to protect this information. And so I know that was a lot to cover, and now we get to go on to the more technical considerations, and I'm going to pass the baton to John at this point.
Thanks, Andrea, and thank you, Dora and team, for the opportunity to share some information with today's attendees. So I want to drop into the HIPAA security rule and spend a little bit of time just going through some of the key tenets and considerations associated with it. So HIPAA security rule really establishes national standards to protect individuals' electronic personal health information that's created, received, used, or maintained by either covered entities and their business associates. While there's three main pillars associated with the safeguards, the physical, administrative, and technical components, today we want to focus mostly on the technical safeguards and drill into that a little bit more. Really, three key tenets of the technical compliance really revolves around being able to protect electronic health information by way of encryption, either in storage or in transmission. Each individual with systems access must have unique credentials to access and communicate PHI. And technology must have some type of mechanism that will log off users within a time frame in order to lock out the system when it's left unattended. Dropping into the technical safeguards, there's really kind of 4 areas of control to think about, whether you're using a cloud-based platform or a locally hosted system. The first access control standard requires covered entities and business associates to implement technical policies and procedures to only allow PHI access by authorized members of the workforce and software systems that have granted access rights according to the Information Access Management Standard of the Administrative Safeguard. This includes password management and unique user credentials. The audit control standard requires the implementation of hardware, software, and procedural mechanisms that record access to and activity within information systems that contain electronic PHI. This includes real-time or near real-time automation to prevent unauthorized access, in addition to retrospective auditing of access by using logs and reporting tools. Integrity controls standard requires that covered entities and business associates implement policies and procedures to protect PHI from inappropriate alteration and or destruction of data. This may include ensuring users cannot delete information, to proper storage and maintenance of data using backups, etc. And then the transmission security control really supports guarding against unauthorized access to ePHI transmitted over an electronic communications network, including transmission of encrypted data. Going into the next slide here, I just want to share some common policies and procedures that we see often being generated based on compliance with the technical safeguards. It's important that organizations develop these policies and procedures from within their institution to ensure that they meet the specific needs and guidelines for that organization, and also vet those policies and procedures with legal counsel and or privacy and security experts. For access controls, one must consider password and unique user identification, role-based access to data based on who can see what, policies for removing access, and password management controls. For example, with role-based access, it's important to ensure that only users who may see certain elements have access to those elements, while others may be locked out from viewing them completely. And I'll talk a little bit about how that impacts different systems in a moment. An example is where maybe individuals have access to see recuperative care services information and may need access to see, let's say, someone's diabetes. And based on consent and the appropriate levels of access, individuals within an organization may or may not be able to see that data. We also want to take into account other policies and procedures, such as termination policies and procedures when staff members leave the organization, and hand in hand with that, making sure that we have guidelines in place for onboarding staff. We also want to have identity proofing, which could include two-factor authentication. I think everyone's somewhat familiar with that, where you may be entering your bank account and be asked for a password, and then a secondary tier of security by way of a text message, or perhaps looking at different pictures and organizing them in a logical fashion. And hand in hand with that, having appropriate password management guidelines in place. The integrity controls should have policies and procedures that really focus on addressing data storage and backups, and protections against alteration and destruction of information, and which would include making sure that protections associated with malware and virus softwares are in place. Audit controls must provide the ability to proactively and retrospectively audit systems. And you'll see here that I've got login monitoring, information systems review, activity review policies and procedures in place. It's just two of three different options. And then transmission controls must cater to encryption and decryption of data in compliance with national standards such as FIPS 140-2. Moving into systems that are common for CBOs to be working in, I just wanted to highlight 3 different areas today. The first is the closed loop referral system, and these are tools that really provide easy access to directory services within a community or a region, such as those services that may be offered under CalAIM to support members seeking social services, mental health services, etc. They often facilitate the request for the referral, tracking and communications of who's receiving those referrals, and also updates associated with fulfillment, along with reporting requirements and the ability to monitor and dashboard different reports and views to make access to information more efficient and easier to basically help individuals look at their daily work lists and manage those individuals they may be working with. Examples of these tools might be Find Help, Unite Us, 211. There's a variety of other tools out there, but there are 3 of the main ones we come across on a frequent basis. Secondary to that is community case management systems. These platforms provide the ability to manage members in a program such as CalAIM at an organization or a community level. In a lot of instances, case management systems will be used by individual organizations, but may also feed up to other tools. However, when it's used at a community level, it offers those working in a clients with different clients, such as those in CalAIM, a robust viewing and collaboration tool that will often track member eligibility and enrollment status, the ability to see and communicate with other care team members, and provide the ability to track and monitor scheduling, task management, and in many cases, manage their work lists daily. Additionally, these tools provide the ability to automate workflows and handoffs, making work produce more efficient. And additionally, they also offer reporting and dashboard capabilities. Examples of these types of tools might be Sprite Health, Ecovia, Activate Care. In some cases, these community case management systems and closed loop referral systems may also have some overlapping features and capabilities. So the ability to track and monitor referrals may loop over to the case management system. The ability to look at the care team and who's part of that care team may also be available in the closed loop referral platform. It'll depend on the solution and how that solution has been rolled out within the community. And then lastly, just thinking about community information exchange. CIE is a similar concept to health information exchange, but offers shared governance and technology to support cross-sector collaboration that also includes social services, justice data, educational data, in addition to some clinical and behavioral health information. These tools provide the ability to have bi-directional sharing of information and often longitudinal views into individuals that offers a more comprehensive understanding of health status, where and who they may be receiving services from, and often also provides caseworkers alerts and reminders and proactive access to information to follow up in a timely manner. Examples of these models may include 211 San Diego, Alameda County's Social Health Information Exchange. And with that, I'll hand back to Lauren.
Thank you so much, John and Andrea. I know it's always been a dream of mine to have access to this much knowledge and actual legal and technical information to meet the needs of my patients. Rather than going into cases, I'd love to open it up to the group. I know you may have questions that you specifically want to ask the presenters. And we also have office hours coming up. So if you have questions about how to design and deliver case conferencing, or want tools and access to tools and resources for how to implement case conferencing, please join our webinar or our office hours. And for Andrea and John, really holding that knowledge and expertise around legal and technical, it's a great opportunity to join. Are there any questions in the chat, Olivia? Or any hands raised?
Let's see.
Ayana, would you like to come off mute and ask your question, Ayana?
I can try. Can you hear me okay?
Yes.
Okay, I've got a tad bit of background noise, but I'll do my best. I was just saying that my organization, we're the lead COC agency for our local homeless response system here in Sacramento. And so we're working through the Housing and Homelessness Incentive Program in partnership with the managed care plans in the county around things like data sharing and referrals and assessments, identifying eligible members for CalAIM who are experiencing homelessness, et cetera. And through that process, there's built into that program some requirements around establishing data sharing agreements with the managed care plans. And at this stage, we're able to share information to the plans via HMIS around like housing status changes. But we are working to get it so it's a bi-directional exchange, right? So that we're able to receive back information from the plans specifically around CalAIM, like enrollments and provider contacts, things like that. So I was wondering, and I'm trying to figure out if there's any implications regard to HIPAA, you know, if we need to have a BAA in place. That's the current conversation we're having right now. So just thought I'd put that out there in case there are other folks who are in a similar position, because I know others are working on this program too, and similar, have similar cases.
Yeah, definitely. Great question. You know, and I obviously can't give any specific legal advice here, but can talk kind of in a, you know, general manner with regard to, you know, kind of thinking through, is there a business associate relationship that's implicated kind of in the proposed arrangement, or excuse me, the existing arrangement that you have with these health plans with regard to the local homeless response system. And at the end of the day, kind of whether or not a business associate relationship exists really turns on what the purpose for the sharing of protected health information is. Is it being shared so that your organization can provide services, you know, to assist the covered entity, in this case, the health plan, to provide healthcare operations and its services to beneficiaries and members? Or are you receiving the protected health information so that you can directly provide services and use that, you know, in your own capacity, such that you can provide services to individual clients? And so if it's the former, you know, for example, and there may be instances in which performing data analytics and other sort of services may indeed be kind of one of the covered functions that's contemplated under HIPAA as requiring a business associate agreement, you know, and being a business associate of the health plan. You know, conversely, if you're receiving these services, you know, and in the instance really it's focused on providing treatment and other services to the clients, again, it may not be a business associate relationship and there may not be a need for a BAA. There may, however, be kind of requirements, kind of getting back to, you know, that guidance that I talked about that OCR has on its website around the information that is shared in the confines of, you know, treatment purposes, you know, regarding whether the minimum necessary standard applies. The health plan may also request a data limited, you know, kind of data set be shared. And in those instances, there may be a data use agreement that it requests. So it really kind of just depends on the relationship and ultimately, again, as I mentioned, the purpose for which the PHI is being shared.
Thank you, Andrea. Appreciate the answer and we appreciate the question. Any other questions for our panel? Feel free to raise your hand. Olivia, I'm scanning. I don't see any in the chat. So if not, I'm going to give everybody just a few more seconds to make sure that there's no questions. But thank you, Olivia, for putting the office hours for both Blue Path Health and Hooper, Lundy, and Bookman in the chat on December 6th, as well as HT2 strategies. So I'm sure it's a lot of information to digest, and know that we will continue to have you know, office hours. Oh, is someone coming off mute? Oh, Nicole, please.
Hi, yeah, I did have a question. We're not a healthcare organization. We provide child development information to families and connect them to local resources. But when medical organizations refer to us, they keep sending us medical records. We don't need them. We don't want them. We keep asking them not to send them. What is our responsibility with that information once it's been provided to us? Because we don't have like a system for housing that.
Yeah.
That is, yeah, great question, Nicole. And Dora, I don't know if you wanted to weigh in. I don't mean to jump in.
No. I was going to defer to you, Andrea. So it's all
First off, generally speaking, yeah, you don't have kind of the obligations under HIPAA to kind of go through the analysis of, hey, this may be a reportable breach that just happened. But, generally speaking, I think your, obligation is to, it sounds like you've been doing this, but immediately notify the healthcare provider that you've received these records, you have no purpose or use for these records, offer to, kind of destroy them or return them in such a manner that, make sure that they are securely destroyed, or if it's paper records that they're shredded, for example, just so that there isn't any kind of potential that these records could be further released. And I think that kind of covers your obligations in those instances if there's been an unauthorized or, unauthorized disclosure of patient records.
But does it retro back to the first one?
Thank you.
Yeah. Thank you, Andrea. Daphne, did you have a question? No. Okay. Well, it looks like we're at time. We really appreciate, and no, those are Pacific time. Someone was asking, the office hours, Eastern Standard Time, those are Pacific time. And so we encourage you guys to join. There's no registration required. Thank you, Lauren. Thank you, Andrea. Thank you, John. We really appreciate you taking your time and sharing your wisdom today. And thank you all for attending. Please know that the slide deck, as well as the recording, will be sent out to everyone who registered. So this information will be available to you. And then if you need additional information, know that we're here as a collective to help support you. So thank you all for your time today. Have a good evening.
Thank you all.
Thank you.